Now that we have more of the basic stuff covered, let's go ahead and start talking about coronary artery disease and stable angina. You might remember when I was talking about atherosclerosis, can be one of the leading causes of coronary artery disease, or CAD. CAD is one of the most common cardiac diseases, and this is caused by a buildup of plaque. If you remember the slides on atherosclerosis, you will remember that this is a buildup of plaque. And you may remember me mentioning that this can eventually lead to coronary artery disease. In CAD, there is ischemia occurring, and there's essentially insufficient oxygen getting to the heart. There are different types of CAD and different severities. It's important to note that there is stable and unstable angina that are related to CAD. I'll get a little further into the stable versus unstable angina, but with your chronic stable angina, or CSA, this can lead to chest pain that mimics that of something like a heart attack. And this is usually going to occur with some form of physical exertion. Let's talk about some of the risk factors for CAD. As you may have guessed, there are both modifiable and non-modifiable risk factors. As you know, non-modifiable risk factors are things that are out of our control, and it includes factors such as age, gender, ethnicity, as well as genetics. You might notice that some of the modifiable risk factors are very similar to the ones that we've talked about in previous slides. So elevated lipids, history of hypertension, smoking, sedentary lifestyle, diabetes, obesity, as well as chronic uncontrolled stress, or even substance abuse. And that also includes alcohol. Generally speaking, CAD and MI are highest among white middle-aged men, but after the age of 65, the incidence in men versus women becomes a little more equalized. However, it's also important to note that with cardiovascular disease, this can cause more deaths in women than men. On average, women with CAD are older than men who have CAD and are also more likely to have other comorbidities. This could be diabetes, hypertension, etc. Now, most women who have symptoms, they may be atypical. So they won't present as that classic MI symptom of that left-sided chest pain. So this will make more sense when I get to one of the upcoming slides when I talk about the different types of chest pain that can occur with angina. There are also other individuals who have a higher genetic predisposition for CAD, and this is going to be African Americans. African Americans have higher rates of hypertension, which can be a risk factor for CAD. So again, genetics are one of those things that we can't really control, but there are those modifiable risk factors that we can initiate, like exercise, weight control, sodium intake. So it's very important to know, of course, what we can control versus what we can't, and to focus on the ones that we can control. Chronic stable angina will lead to chest pain, and this chest discomfort is going to be a reversible form of myocardial ischemia. Now again, remember, there's stable and unstable angina. The big things to remember with chronic stable angina is that this pain will usually go away within about 5 to 15 minutes, either with medications or with rest. Unstable angina is angina that does not go away with medications or rest. You may wonder, how does chronic stable angina occur? Well, there's an increased demand for oxygen, or there's a decreased supply of oxygen. And oftentimes this can happen with some form of activity. For many people who have chronic stable angina, they'll find that it's the same types of activities that will provoke this chest pain. It could be mowing the lawn, walking up 2 flights of stairs, unloading groceries, walking more than 5 minutes at a time, etc. Now again, with your stable angina, it will resolve when they decide to rest or when they take a certain medication called nitroglycerin, which I'll talk a little bit more about later. The chest discomfort occurs with stable angina because of lactic acid. Lactic acid release will irritate the nerve fibers, and then it causes pain in those cardiac nerves. And then it's called referred cardiac pain. And this could be the chest, this could be shoulders, neck, lower jaw, as well as arms. And I'll show you an image on the next slide. Here are all of the areas that one can experience any kind of chest pain, regardless if this is stable angina or unstable angina. Now, if you think of someone who's having a heart attack, you think of that classic left-sided chest pain. So if you look at this image here, they have chest pain occurring on the left side or even in the middle of the chest, and then it goes down that left side of the arm. However, not everyone has pain here. Sometimes it can be right in the middle of the chest, just neck pain. It can be kind of a tie appearance or even epigastric pain, or it could simply be pain in between their shoulder blades. The symptoms will usually not be a sharp or stabbing pain. Instead, this type of pain is going to be more of a pressure or aching, or even a squeezing or heavy feeling. If they have the pain or discomfort around the neck, it could feel like they are choking or they have pressure on their neck. Now, everyone's a little bit different in how they present with their angina-like pain in terms of location. Males traditionally tend to have more of that left-sided chest pain with the radiating left arm, whereas females are the ones who tend to have pain around the neck, that epigastric pain or even heartburn. So they don't have that classic, oh, the left side of my chest hurts with that shooting left arm pain. So it's important for your patients to know, if they do have stable angina, where this pain can occur. So when do they take their medications, or when do they decide that it's time to rest, or even when do they decide that it's time to go to the ER? When assessing patients with any kind of angina, it's of course critical to get a good assessment, but that's going to include health history, so your subjective data, as well as your objective data. When talking with a patient, you want to see if they have any history of heart issues, if they have any history of hypertension, what their diet looks like, have they ever been told that they have high lipids, have they ever been told that they have atherosclerosis, or do they have any family history of cardiac issues? Do they take any medications? The medications in general can provide a lot of information. I think I mentioned this on a previous slide in that sometimes your patients will tell you, oh, no, I have no medical history. And then they tell you that they take certain medications that are prescribed by their doctor. So sometimes they don't associate that they have a chronic condition, even though they take medications for it. So getting a medication history can go a long way for your patients. With your patients who have chest pain, it is really important to, of course, look at your patient and see how they're doing. If they are having active chest pain, this means that there should be a very rapid assessment, because with chest pain, you probably should be worried about something like an MI. A myocardial infarction is a form of acute coronary syndrome, or ACS. We are just going to touch on ACS. This is something that you get further into when you get to critical care, but you at least need to know what the difference is of acute coronary syndrome versus stable angina. Now, if you note on this bullet point here, history of present illness, you absolutely want to get the story of how these symptoms occurred. What was the patient doing when the symptoms started? How long have they been going on for? Was this the first time it's happened? Did they take any medications for it? Are they still having the pain? And if they are not, what were they doing when it went away? Now again, if your patient is symptomatic with chest pain, you need to delay collecting some of this data until interventions are started. So these interventions I'll go into a little bit further in the upcoming slides. With your nursing assessment, you of course listen to heart sounds. Does this patient have a regular rate and rhythm? What's their respiratory rate? What do their breath sounds sound like? Feel their peripheral pulses. Is there a pulse deficit? Or in other words, does it feel like their peripheral pulses are unequal? Do they have tachycardia? Are they bradycardic? Typically, there's going to be an EKG done. So is there a dysrhythmia? JVD, so jugular vein distension. This can be very telling if someone has fluid volume overload or a history of right-sided heart failure. Any patient who has chest pain can present with appearing anxious, fearful, restless, distressed. Of course, some of this could be with fear related to, oh my goodness, am I having a heart attack? Am I going to die? However, some of that can also be related to the fact that this patient is not oxygenating appropriately. Some of the acute interventions are ones that you guys already know. For example, positioning. If your patient is struggling to breathe, then they should be either in a high Fowler's or, at minimum, a semi-Fowler's position. Supplemental oxygen may be indicated. Of course, if your patient is struggling to breathe, then you're going to apply oxygen. So we are looking at everything on the patient. Of course, we're looking at that pulse oximetry because that gives us measurable data. However, you also need to look at the respiratory effort of the patient. Even if they're sitting at, let's say, 95% room air, but they're breathing very hard and they're tachypnic and they have more labored breathing, so again, breathing hard, then you would apply oxygen to help them breathe a little bit better. I probably don't even need to tell you this, but vital signs will of course be obtained, but a 12-lead EKG will also be done to see what the patient's cardiac rhythm is. We are particularly concerned about, is this patient experiencing stable angina, or are they entering into acute coronary syndrome, and are they having a myocardial infarction? Pretty much all patients who appear to be having chest pain related to the cardiac system will receive nitrates. So again, nitroglycerin. This is usually a sublingual tablet, so it goes under the tongue, and they can receive it every 5 minutes, and they can receive up to 3 doses. So total of 3 doses within 15 minutes. They can also receive an opiate drug such as morphine to help with some of the pain, which actually also helps with oxygenation. And they can also receive aspirin, especially if they really are suspecting that this patient is having an MI. The diagnostics will be very similar to the ones that I have talked about on previous slides, such as troponin. They'll probably also do things like a CBC as well as a CMP, because they are in particular looking at things like electrolytes as well as is there any anemia occurring. Chest x-rays are frequently done because it's a quick diagnostic. It can be done at the bedside if you're in the ER or in the hospital. But this can tell us if there's any cardiomegaly or if there are any more serious conditions that need to be evaluated and treated more immediately. Some other types of diagnostics that can be done are a thallium scan, and this is a type of scan that uses a radioactive tracer. This tells us how much blood is reaching the different areas of the heart. A CMR is a cardiovascular magnetic resonance imaging, so in other terms, a cardiac MRI. We know that an angiography is the X-ray imaging of blood vessels that use a contrast dye, but a CTCA is a CT coronary angiography, and this more or less takes pictures, or in other words, angiograms of those coronary arteries, and this can tell us if there are things going on with the heart, such as any blockages. Another test that might be done is a cardiac cath. The advantage to cardiac catheterization is if they do see that there are blockages, they can intervene right away. Now you may wonder, what is the difference between a cardiac cath and a CTCA? A CTCA is using a CT scan, and this is going to be a non-invasive form of evaluating those vessels, whereas your cardiac cath is going to be a procedure where there's a catheter inserted into an artery that goes up to the heart. If the patient's stable enough, they may do an exercise stress test, but this is not going to be someone who's having active chest pain right now. And then, of course, 12-lead EKG. Management of stable angina is going to come with medications. At the very least, it will include nitrates. If you look at the images on the right, these are different types of nitrates. So nitrostat is the most common one, or nitroglycerin. In this tiny little bottle, it's really small, the tabs are really tiny, and they are sublingual, so they go under the tongue. With the spray, this one right here, this is also sprayed sublingual, but there's no tab that has to dissolve. Nitrates are used when someone's having chest pain. So again, if you have someone with stable angina, if they start experiencing chest pain, they will, 1, rest, but they're also going to take their nitro. So they will either use their spray or put the tablet under their tongue, and they can take 1 dose, and then after 5 minutes, if they still have chest pain, they're going to take a second dose. If they, after a total of 10 minutes, so after the second dose, if they still have chest pain, they will take that 3rd dose, but they're probably also calling 911. If they are taking 3 doses, there's a possibility that their stable angina has now turned into unstable angina. Some of you may have also seen Nitrobid, which is a nitroglycerin ointment that can be used in the hospital sometimes. And it's a really small rectangular piece of paper basically. And you put nitroglycerin paste or ointment on here. So on the order, it'll tell you a 1/2 inch or 1 inch, 1.5 inch, or 2 inches. So you'll kind of smear that ointment on there and then you'll place it on the patient's skin. This type would be a form of the long-acting nitrate. So usually with that one, they'll keep the nitro on for 12 hours and then they'll leave it off for 12 hours. Patients may also get several different medications, such as antihypertensives. These are medications that you will get a little bit further into in your next pharmacology class, but they're different classes, and all of them work a little bit different on the body, so they all have their own roles. In the case of stable angina, ACE inhibitors, for example, can be used for those at higher risk of cardiac events, especially those who have a lower ejection fraction, which I will be discussing a little further when we get to heart failure. Pretty much most patients with stable angina will have a discussion about lifestyle modifications, especially if they have atherosclerosis or high blood pressure or diabetes. So if they have comorbidities, the management of those are going to be critical to prevent stable angina from turning into something more serious. It's critical for patients to have a discussion about when to seek immediate medical attention. So again, if they have chest pain that isn't going away with rest or with nitro, they should be calling 911. Here's a slide a little bit more on your cardiac cath, and this can be really useful for patients who have atherosclerosis with CAD, especially if they're having angina. This can help to open up those arteries more. For example, if you see this image on the right here, you have that atherosclerosis, so that plaque that's built up. They'll go in with that catheter, and there will be this kind of mesh lining around a balloon. They'll inflate that balloon, and that mesh will expand. Then the balloon is deflated, and then the catheter is removed. That mesh will stay in place, and it kind of smushes that fat off to the sides so that that artery will regain a lot of its flow. A cardiac cath can be used for patients with stable angina, but it's usually going to be used more frequently for patients with acute coronary syndrome. If you look at this image here, you have two of them. First is before and after intervention. So if you look at this image on the left, you have two areas of blockages. This one is pretty blocked, and this one is almost completely blocked off. So what they did in this image is they did a percutaneous coronary intervention, or PCI. So they went in during cardiac cath, they visualized for any blockages, and then they opened it up after placing a stent. So if you look at this image on the right, this is after that stent was placed and that artery was opened back up. This chart is actually from the Lewis MedSurg textbook, but I feel like it's a really good summary of what's done for a patient who has chest pain. On the left here, we have our box that quickly describes what kind of diagnostics might be ordered. So what would you potentially anticipate as the RN? The right side of this chart is really good to look at for a really quick summary of what the differences in care are for stable angina versus acute coronary syndrome. For the purpose of this class, we're focusing on stable angina. So while I'm not expecting you to memorize the medications, you should at the very least know that some antihypertensives may be ordered, especially if they have other comorbidities, but nitroglycerin is often going to be indicated because this is going to help when they start having symptoms. Let's talk real quick about acute coronary syndrome versus stable angina. I mentioned previously that stable angina can turn into unstable angina. So in other words, stable angina goes away with rest or medications such as nitroglycerin, whereas unstable angina does not. Unstable angina is a non-STEMI. So this is a form of a myocardial infarction. So this would need intervention, but the one that needs immediate intervention is going to be a STEMI. This is someone who has a complete blockage and they are not perfusing well. Unstable angina and a STEMI, these fall under the category of acute coronary syndrome. Again, acute coronary syndrome is something that you will be getting into a little bit later in the program, but you should at least know what the difference is between stable angina versus unstable angina. This slide is actually a summary from one of the tables in your IGGI textbook, And this is a really good one to look at to see why is it so much more difficult for older adults with the management of CAD. First off, their chest pain or their symptoms may not be those classic symptoms of stable angina or even chest pain in general. So it's really important to educate the patient as well as any caregivers that may be involved on warning signs that they would need to look out for, that this has become an emergent situation. Some of the medications that may normally be prescribed for CAD or stable angina may be used with greater caution in older adults because of the side effects. As you know, older adults can also sometimes have musculoskeletal issues, so we still want them to exercise, but we may need to make some modifications so that they can still stay active, but we need to accommodate to their needs. Another thing to note is that the warm-up periods should be a little bit longer for older adults to help to warm up those muscles, but this also means that cool down periods may also take a little bit more time. And part of that has to do with the pulses taking a little bit longer to go back to baseline after exercise. Now let's begin talking about heart failure. What is heart failure? Heart failure refers to the inadequate pumping and or filling of the heart. So this has to do with the left as well as the right side of the heart, but also has to do with systole and diastole. A failing heart is unable to meet the oxygenation needs of the body, so the more severe the heart failure is, the worse the oxygenation is in the body. There are several different types of heart failure. There's acute heart failure, which is usually going to be because of something else in the body that's causing it. For example, severe anemia. Once the anemia is managed and corrected, then the heart failure will also resolve as long as there is no permanent damage that occurs. Chronic heart failure, on the other hand, is chronic and progressive. You may also hear chronic heart failure being referred to as congestive heart failure. However, this is not really an accurate term anymore because not all types of heart failure have pulmonary congestion. Heart failure is usually going to have other cardiovascular disease that leads to the heart failure. Someone who has hypertension, especially if it is poorly controlled, history of coronary artery disease, history of myocardial infarction, as well as individuals with a history of some sort of valve disease. In the US, the rates of heart failure are increasing, and there are several factors that are involved with that. One, our aging population is growing. So, in other words, individuals are living longer, but you also have individuals who have cardiovascular events, for example, an MI, who are now surviving. If someone's had an MI, it can later on lead to heart failure over time. Many of our older adults that are admitted to the hospital in the US are actually there for complications related to heart failure. Heart failure will occur when the normal cardiac mechanics are not able to regulate the cardiac output. And there are several different factors that can, if you remember, affect cardiac output. Preload, which if you remember, is the volume of blood in the ventricles and at the end of diastole. Afterload, which refers to the peripheral resistance. Contractility, which is the heart's ability to squeeze and eject blood. And of course, heart rate. If there are any changes to these factors, especially over a long period of time, then it can lead to heart failure. There are two different types of heart failure, left and right-sided. It's also important to note that there are two subcategories of left-sided heart failure, which are systolic and diastolic. Left-sided heart failure is the most common type of heart failure, and this is going to be caused by left ventricular dysfunction. This will ultimately prevent the forward blood flow, so this causes a backup of blood in the left atrium or the pulmonary veins. And if there is backup in the pulmonary veins, this is what leads to that pulmonary edema and congestion. It used to be referred to as congestive heart failure a lot, and that was because of that fluid leakage into the alveoli that led to that pulmonary congestion and edema. And the symptoms of that can include shortness of breath, crackles in the lungs, as well as a pink frothy sputum when the patient coughs. Now, you will still hear heart failure in general referred to as congestive heart failure, but just know that not everyone has that pulmonary edema. Let's talk about our first subcategory of left-sided heart failure. The first one is systolic heart failure, and this is the inability of the heart to pump effectively. Usually this is going to be because of underlying cardiac conditions like history of MI, uncontrolled hypertension, cardiomyopathy, or even valvular heart disease. With systolic heart failure, the left ventricle will lose its ability to provide enough ejection pressure, so enough pressure to push the blood out of the ventricle. The hallmark sign of systolic left-sided heart failure is decreased ejection fraction. The ejection fraction is the percentage of blood that's ejected from the heart during systole, and this will range between 50 to 70% and can go as low as 40% with ventricular dilation. As it decreases, that also means that tissue perfusion will also decrease, which means that blood will start to build up and accumulate in those pulmonary vessels, which will then potentially lead to things like pulmonary edema. Sometimes systolic heart failure will be referred to as forward failure because the cardiac output is decreased, and this is going to lead to that backup of fluid. So you can almost think of it as this type of heart failure prevents the heart from pushing the blood forward to where it's supposed to go. These patients tend to be at much higher risk for cardiac death, especially those who have an ejection fraction that's pretty low. So really anyone who has an ejection fraction that's below 30%, they are going to be closely monitored because again, they're going to be at higher risk for cardiac death. Diastolic heart failure is the inability of the ventricles to relax and fill with blood during diastole. Diastolic heart failure is also referred to as left-sided heart failure with normal ejection fraction because it doesn't have to do with the heart pushing the blood out of the heart, but has more to do with the heart filling with blood. With this type of heart failure, there is a decrease in stroke volume and cardiac output because the heart is unable to fill completely. Usually with your diastolic heart failure, this is going to be caused by some sort of left ventricular hypertrophy, such as most commonly chronic hypertension, or it can be from MI depending on where the ischemia is, as well as valve disease and cardiomyopathy. The diagnosis is going to be made based off the heart failure symptoms, but they will also do an echo to see what that ejection fraction is. If they have the symptoms of left-sided heart failure with a normal ejection fraction, then that's going to be diastolic heart failure. Now let's discuss right-sided heart failure. Common causes include left ventricular failure, and this occurs because the heart on the right side is kind of having to pick up the slack for that failing left side. So eventually the right side is also going to tire out, and then this individual will have left and right-sided heart failure. History of right-sided MI is another cause, as well as pulmonary hypertension, which kind of also ties into the chronic causes that I'll discuss on the next slide. Now, what happens with right ventricular failure? Well, the right ventricle cannot empty completely. This will lead to a backup of blood into the right atrium as well as the venous circulation. So you can almost think of it as a clogged sink. Because that blood can't enter into the heart, it starts to back up in other areas. So these are the individuals who will develop jugular vein distension, or JVD, hepatomegaly, splenomegaly, as well as vascular congestion of the GI system and peripheral edema, particularly pitting edema. This slide is more or less a reiteration of the causes on the previous slide. So with your individuals who have chronic conditions like chronic pulmonary disease such as COPD, it can lead to cor pulmonale, which is when there's right ventricular dilation and hypertrophy, meaning it can't relax and fill as well. Left-sided heart failure is usually the primary cause, but it can also be from pulmonary hypertension as well as a history of right-sided MI. But acute types of right-sided heart failure can also be from right ventricular infarction, so an acute MI as well as a PE. High output failure is not as common as the other types, so we're not going to focus on this one too much, but you'll at least know what high output failure is. And this can occur when cardiac output is either normal or above normal, unlike left and right-sided heart failure where there's typically a lower output state. This type of heart failure is caused by acute conditions, septicemia, really high fever, bad anemia, as well as hyperthyroidism. So with this type of heart failure, it's considered, again, acute heart failure. So if the underlying cause is addressed and treated within a good amount of time, then typically the patient will go back to a normal level of functioning. However, it just depends on comorbidities as well as how quickly the symptoms are addressed. Different governing bodies have different classification styles. So the American Heart Association, for example, uses ABCD, whereas the New York Heart Association uses 1, 2, 3, 4. And this basically summarizes how severe the patient's symptoms are. With the New York Heart Association, stage 1, for example, is that there's some sort of cardiac disease present, but there's really no symptoms, and there are no limitations presently with the patient's ability to perform activities of daily living or their physical activity in general. With stage 2, there are mild symptoms and maybe slight limitations during regular activity, but otherwise they're still able to perform activities that they normally would. A stage 3 is more significant limitation due to the symptoms. So some of these patients may really only be comfortable at rest. And if they have, let's say, left-sided heart failure, they may only be comfortable when sitting in an upright position. So these might be the kind of patients that you have to keep in a more semi-Fowler's or high Fowler's position because they may have orthopnea. A stage 4 would be severe limitations. So these are people who have symptoms even when they're sitting down and at rest. So these people might need oxygen therapy as well as, of course, medications, but some of these individuals may also be on a cardiac transplant list. Compensatory mechanisms will really depend on, is it something that's acute, such as an acute MI, or is this more slow and progressive form of heart failure? The body's ultimate goal is to maintain proper cardiac output and to especially continue to provide oxygenated blood to the important areas of the body, such as the brain. There are generally 4 different types of compensatory mechanisms, and I'm going to very quickly overview these just so you can see how they kind of tie into heart failure. The SNS response is usually the first, but also the least effective. It might help over a short period of time, but it will ultimately cause the heart to work a lot harder. With the stimulation of SNS, we know that catecholamines such as epi and norepi are released. So this will increase heart rate, especially with the epinephrine, which will improve cardiac output at first, but over time, again, this will cause more harm than good because it's going to cause the heart to work a lot harder. The neurohormonal response is mostly going to be related to the kidneys. With reduced blood flow to the kidneys, this is going to cause the release of renin, which will then initiate the renin-angiotensin-aldosterone system, also known as RAS. This process will ultimately lead to sodium and water retention, as well as increased peripheral vasoconstriction, which will increase the blood pressure. The decreased cardiac output will also cause a release of the antidiuretic hormone from the posterior pituitary, which will then increase water reabsorption of the kidneys, which also is contributing to the water retention. As a result of RAS and ADH, this is going to lead to increased blood volume, or in other words, fluid volume overload. Some other hormones that can be released are your natriuretic peptides, and these are neurohormones that will work to promote vasodilation, as well as diuresis. You all might recognize your B-type natriuretic peptide, or BNP, as a laboratory value. And what the BNP really tells us when we look at a lab is how hard the ventricles are working. As BNP is released by the ventricles, this is caused by an overstretching, usually because of fluid volume overload. You also have to look at age for BNP as well. If we have slightly elevated BNP levels, this could be either from age, or it could also be from a history of cardiac dysfunction in general. Over time, as our heart is working harder, it can lead to ventricular remodeling. Angiotensin II plays a large role in this because it results in progressive myocyte contractile dysfunction over time. And really what happens with ventricular remodeling is the muscle mass will increase with size, which will then lead to increased cardiac wall thickness. So if you think of a bodybuilder, for example, the more you work out that muscle, for example, the biceps, the more they're going to grow. The heart is a muscle, so the more it works out, the more it's going to grow in size. While this may be desirable with, let's say, your biceps, this is not so desirable with the heart. This is something that takes a long period of time. It's not going to happen overnight. So this is someone who's had heart failure or very severe heart failure for a longer period of time. With ventricular remodeling, this can be really life-threatening for individuals because it can lead to dysrhythmias as well as sudden cardiac death. As the ventricular remodeling continues over time, this is going to lead to worsening contractility of the heart. So these individuals will usually require more oxygen via nasal cannula or mask, or they may even have poor artery circulation, which can then lead to further ischemia and dysrhythmias. The chambers of the heart can also change because there's enlargement of the chambers. Now, keep in mind, these chambers aren't getting bigger. It's simply that those cardiac walls are becoming thicker. At first, this may help because this helps the muscle fibers stretch more in the heart because it's trying to accommodate for that increased need for blood volume. So as it stretches, the more it's going to affect contractility and therefore cardiac output. These are some images of ventricular remodeling. Up here we have enlarged atria, which bigger is not always better. And down here we have the enlarged ventricles. We also have thickened heart walls. So we can, again, have enlarged ventricles, but we will typically have a thickening of those walls too. So that's going to affect contractility. But just because we have enlarged atria, for example, it doesn't mean that the heart is going to be able to use them as effectively because those cells are just so overstretched. As a quick summary of heart failure, it's going to be caused by something chronic, such as chronic uncontrolled hypertension, CAD, individuals who have a history of MI, for example, but it can also be from those valvular changes. Over time, as the heart is working harder, it can lead to structural changes such as ventricular remodeling, so hypertrophy and dilation. The assessment techniques are going to be pretty much exactly the same as the stuff that we've already talked about, but it is especially important to ask your heart failure patients about activity levels because of that staging. So the classification and staging of heart failure helps us to get a better understanding of how progressive their heart failure is. This also helps you to guide what your nursing interventions are going to be. For example, if your patient is short of breath laying down, then you may need to educate them that they need to sleep with several pillows so that their head is propped up a little bit so that they're able to breathe when they're sleeping. Now that we have a better understanding of what left versus right-sided heart failure is, let's go ahead and start talking about some of the symptoms. Left-sided heart failure, because you have that backflow into the lungs, this is going to lead to the pulmonary symptoms, so shortness of breath, especially with exertion, and they can also get paroxysmal nocturnal dyspnea, which is shortness of breath that kind of occurs in the middle of the night and then goes away on its own. Fatigue and weakness are pretty common, and this has a lot to do with oxygenation. Chest pain, palpitations, fast heart rate, a lot of this has to do with those compensatory mechanisms, as well as if they have any, let's say, ventricular remodeling, then you worry about them having dysrhythmias, which can lead to chest pain or palpitations. If you look at this image on the right, this is a really good quick snapshot of some of the symptoms that can occur with left-sided heart failure. For example, if you look at the fingers and the feet and the lips, they're blue, which would indicate cyanosis. With right-sided heart failure, remember that you're going to have that backup of blood in the systemic area. So this is not pertaining to the lungs. So this has to do with the extremities as well as some of the vital organs such as the liver. It can lead to JVD, which if you look at this image here at the top right, it's not this right here. That's your sternocleidomastoid muscle. The JVD is this guy right here. So that is pretty enlarged, and that has to do, again, with the backup of that blood. It can also lead to ascites, partially related to hepatomegaly. It can lead to weight gain, which would be more related to fluid gain, so fluid volume overload. If you look at this image on the right here, you'll see that this lady has cyanosis of the toes, the fingers, and this is just because your heart failure patients don't oxygenate well. But you also have that edema here. So again, with your right-sided heart failure patients, they'll have that edema, and typically it will be pitting edema. There are some laboratory assessments or imaging that may be done, and this is pretty much the same as a lot of the other cardiac imaging or diagnostics. With the electrolytes, we're really looking at sodium and potassium here, especially if they are retaining fluids. BUN and creatinine will also be checked out. BUN can be elevated, but that's also going to depend on their kidney function. We also look at liver function tests because remember that right-sided heart failure can lead to hepatomegaly. BNP will typically be elevated because, again, those ventricles are working a lot harder than they should. Chest x-rays can be done to see if there's any cardiomegaly, as well as any pulmonary congestion or even interstitial pulmonary edema. An echo may also be ordered, and this helps us to understand what the chamber sizes are in the heart, but more importantly, to look at that ejection fraction. So remember that there is decreased ejection fraction with systolic heart failure, whereas diastolic left-sided heart failure will have a normal ejection fraction. A MUGA scan, or a multi-gated acquisition scan, is a non-invasive diagnostic test that might be ordered, and this helps the providers to look at the pumping of the ventricles. Now I want to kind of quickly go over the general clinical manifestations that you are looking for in your heart failure patients. Fatigue is a big one. It's one of the earliest symptoms of chronic heart failure. The patient may note that they're feeling a little more fatigued after their normal activities and may even eventually limit the activities that they normally perform. This fatigue is usually caused by decreased cardiac output, impaired perfusion to those vital organs such as the liver and spleen, as well as kidneys, decreased oxygenation of the tissues, as well as anemia, so lower H&H. The anemia can really occur from a variety of factors. It could be an already underlying condition, could be from a history of renal disease, or even poor nutrition. Remember, if someone is really tired, they may not have the energy to eat well-balanced meals. Dyspnea is a common manifestation of chronic heart failure, and it's caused by the increased pulmonary pressure because of that interstitial and alveolar edema, particularly in left-sided heart failure. Shortness of breath can occur with really mild exertion or even at rest, depending on how progressed it is. Orthopnea will often accompany shortness of breath, so it's going to be really important to carefully ask patients about any adaptive behaviors, such as sleeping positions. So how many pillows do you sleep with? Do you sleep in your own bed at night, or do you find yourself sleeping in an upright position on the recliner in the living room? Paroxysmal nocturnal dyspnea is going to occur when the patient's asleep. So the patient will kind of awake in a panic and has this feeling of suffocation and a really strong desire to either sit or stand up. Paroxysmal nocturnal dyspnea, or PND, can be caused by the reabsorption of fluid from dependent areas when the patient is laying flat. So you'll especially see this when you have patients with right-sided heart failure. Tachycardia is an earlier sign of heart failure as well, and it's one of the body's first responses to compensate. So if you remember, that is the SNS response. While the SNS response is initially going to be more favorable because it's going to help with increasing cardiac output, over time it's going to be very harmful to the heart and will eventually lead to exacerbation of the heart failure. And another one that's not on this list is cough. Cough can often be associated with heart failure, and this can sometimes be the first clinical symptom. It'll usually begin as a more dry, non-productive cough, and it can oftentimes be misdiagnosed for asthma or other lung diseases. This cough is usually going to be unrelieved by positional changes or even over-the-counter cough medicine. Now, it's also important to note that if one does have a cough, you also have to look at medications because there are some meds that can cause a dry cough, such as ACE inhibitors. Cough can partially be related to edema, especially if you think about pulmonary edema. When someone has pulmonary edema, though, it's usually going to be more of a wet-sounding cough, and if it is productive, it's going to be more of a pink frothy sputum, and that will be related to your left-sided heart failure. Dependent edema and abdominal edema, or ascites, would be more related to right-sided heart failure. Weight changes are things that patients really need to pay attention to. So they should be weighing themselves every single day. And if they have more than 3 pounds within a couple days, it could be indicative of acute decompensated heart failure, which we're not really going to go into, but just know that they should be contacting their provider. Urinary is another big one that should be addressed. So when you have a patient with heart failure, at night when they're laying flat, that fluid is going to be reabsorbed, and then it can cause increased urination. So it's kind of similar to that paroxysmal nocturnal dyspnea in terms of reabsorption of fluid. So when you ask patients about urinary habits at night, of course, if you have an older adult, sometimes they usually will get up 2 to 3 times a night. But when they have heart failure, you need to monitor if there are changes. Maybe they used to only get up 1 or 2 times a night, and now they're getting up 4 or 5 times a night. When assessing the skin, just assess their general appearance. Do they appear more of a dusky gray? And that's something that you may see with patients who have poor perfusion or poor oxygenation. So in general, our skin color, we want it to be even in skin tone, and it should be consistent with ethnicity. Behavioral changes are mostly going to be related to oxygenation. So if they are restless, that could be a sign that they're poorly oxygenated, but with chronic poor oxygenation, confusion, and decreased attention and memory are really big ones that they may see. And lastly, chest pain. And this is just because the heart is basically working harder. In this image, we have pitting edema of the feet. So you see lots of edema here, and you see 4 finger imprints there. We grade our pitting edema as 0, which would mean that there's no imprint of our finger. And then there's a 1, 2, 3, and 4. I would recommend looking at those just to see how you would grade them appropriately. This one here, definitely a 4+. This image here is a good quick reference guide of how to assess cardiac clues. Now we have our drugs. If you look at the image on the left, this is a mnemonic to remember what kind of medications may be administered for a patient with congestive heart failure or heart failure. So upright position, nitrates such as nitroglycerin, Lasix to help if they have fluid volume overload, oxygen, of course, if they are having a hard time breathing. Aminophylline is a bronchodilator that can actually be used with chronic conditions like asthma, and it's going to help to open up the airways. Digoxin can be used for individuals who have abnormal heart rhythms. And then the FAST acronym. So fluids need to be decreased, especially if they are retaining fluids. Afterload is hopefully going to be decreased. Sodium restriction to help with some of that fluid volume overload. And then testing. If they're on digoxin, then they should be within a therapeutic range. ABGs may be closely monitored to see how well they're oxygenating, and potassium levels, especially if they are on Lasix. Just to give a quick overview of what these medications can be used for with heart failure, let's go ahead and start with diuretics. So we have your Lasix or furosemide, which is a loop diuretic, but then you also have other types of diuretics like spironolactone or aldactone. Diuretics in general are going to be used to reduce edema as well as pulmonary venous pressure and preload. So these act on the kidney by helping to promote that excretion of sodium and water. You have to watch out for the potassium level, especially for your loop diuretics, because these individuals are going to be at higher risk of hypokalemia because we are excreting that urine so fast, it doesn't give the kidneys a chance to reabsorb some of the potassium it needs to keep. Aldosterone antagonists, such as aldactone, is going to block aldosterone effects of the heart, and these are the potassium-sparing diuretics, but you still have to watch out for the potassium levels as well as sodium levels. As for the ACE inhibitors, ARBs, and beta blockers, I guarantee all of you have had patients with some of these medications. So let's start with ACE inhibitors. Examples are captopril, benazepril, so these are your pril antihypertensives. These will be the primary drug of choice for blocking RAS in systolic heart failure, and these will help by blocking angiotensin 1 to reduce those levels of angiotensin 2. Angiotensin II receptor blockers, or ARBs, are examples of losartan or valsartan, and these can be used as vasodilators, but they also bind to angiotensin II receptor sites, which will then help to decrease the secretion. Beta blockers are your OLOLs, so metoprolol, carvedilol, and these will block those negative effects of the SNS. So these can help to not only control blood pressure, but they can help to decrease the heart rate. Vasodilators such as nitrates or nitroglycerin can help to cause vasodilation, so it's going to help improve cardiac output. Positive inotropic drugs are going to be, for example, digoxin, and this will increase the force of cardiac contraction, so it's going to help the heart pump more effectively. Our general interventions are going to be improve cardiac output as well as oxygenation for our patients. A lot of our interventions will really depend on how severe the symptoms are, as well as what type of heart failure they have, but in general, they'll be fairly similar. So the goals are going to be increased gas exchange, increased perfusion, as well as preventing or managing pulmonary edema, as well as dependent edema for your right-sided heart failure. Fluid restriction is not generally required, but it just depends on the symptoms. So if someone has more progressed heart failure, then they will probably be on a 2-liter a day restriction, but they could even be at a 1,500 milliliter a day. If they are on a fluid restriction, they may complain of having a dry mouth. So you can encourage things like ice chips, gum, hard candy, and this can help to kind of curb that sense of thirst. Daily weights are really important, so you have to encourage them to weigh themselves daily. Usually when I tell my patients about daily weights, I tell them to just go ahead and weigh themselves first thing in the morning when they get up and they're about to take a shower. Monitoring for weight gain is also very important. So 1 kilo or 2.2 pounds of weight gain or loss is equivalent to 1 liter of retained or lost fluid. If there's rapid weight gain, so 3 pounds in a week or 1 to 2 pounds overnight, they have to contact their provider right away. These patients will generally also be on a sodium-restricted diet, so usually less than 2 grams a day. If they have more progressed heart failure, then usually it's going to be 1 gram per day. So you have to encourage looking at labels as well as no added salt to their foods. Activity and rest, we still want patients to move around, but they may need to do more rest periods. So energy conserving and energy efficient behaviors. Again, this is really going to depend on how progressed their heart failure is. They may also need cardiac rehab, which is kind of like exercise training that's specific to someone with cardiac issues. Health promotion in general is going to include vaccinations as well as reducing risk factors. So avoid getting sick. And that summarizes it for heart failure. I know it's a lot of information, but just make sure you're slowly going through the book and make sure you're filling out the comparison charts, and that can help you to identify what the similarities and the differences are. Now let's talk about valve heart diseases. You have mitral valve prolapse, aortic stenosis, and aortic regurgitation that we're going to focus on. Let's begin by talking about mitral stenosis. Rheumatic fever is the most common cause, and with rheumatic fever, it can lead to scarring of the heart valves, especially the mitral and aortic valves. Because valvular stenosis can increase the workload of the heart and can cause further heart issues, this will lead to potentially pulmonary congestion as well as right-sided heart failure. Over time, this will lead to decreasing cardiac output. Now, people with more mild forms of mitral stenosis may not even know that they have it, so they may be completely asymptomatic. Symptoms usually will include shortness of breath, especially on exertion, orthopnea, as well as palpitations, dry cough, so they will potentially have left-sided heart failure involvement over time. Mitral regurgitation or insufficiency can be caused by a variety of reasons, such as mitral valve prolapse, rheumatic heart disease, and usually it's going to be a more slow progression, so the patient may be completely asymptomatic for a really long period of time. Over time, as it progresses, they may start to notice that they're feeling more fatigued, they may not be able to participate in activities they were once able to do, and they may even notice that They have a fluttering of the heart or that it feels like it's moving faster, which could be from AFib. Mitral valve prolapse is actually pretty common, but most patients don't have any issues that develop. This does have a genetic component, and what happens is that one or both leaflets will enlarge, stretch, and then prolapse into the left atrium during ventricular systole. Blood then leaks back into the left atrium, and that leads to mitral regurgitation. Aortic stenosis is the most common valve dysfunction in the US, and it's thought to be more of a wear and tear condition. Aortic stenosis can lead to right-sided heart failure over time. The best way to avoid aortic stenosis is to control risk factors, such as keep cholesterol and lipids under control. If someone's diabetic, then make sure that it's well controlled, as well as chronic hypertension, ensuring that the high blood pressure is controlled as well. And lastly, aortic regurgitation or insufficiency will usually result from non-rheumatic conditions, which can include infective endocarditis, congenital abnormalities, hypertension, or even Marfan syndrome, which is a rare systemic connective tissue disease. This is another one where the patient may be completely asymptomatic for a long period of time, but over time they can start to develop things like exertional shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, or even palpitations. But usually if they have palpitations, this is usually going to be more related to dysrhythmias, which can happen in more progressed or severe disease. For these patients, usually want to ask about the symptoms. How long is it taken for the symptoms to develop? Any history of cardiac issues, any family history of cardiac issues? Have they had any history of IV drug use? And this is particularly going to be related to infective endocarditis. In general, a more conservative approach is preferred. So non-surgical management will really focus on drug therapy and rest. During the course of valvular disease, though, left ventricular failure with pulmonary or systemic congestion may develop. Common drugs will include diuretics, beta blockers, ACE inhibitors, DIG, as well as oxygen, so it's going to look really similar to heart failure. Surgical management includes invasive as well as non-invasive methods. A balloon valvuloplasty, for example, is this image at the top left up here, is an invasive non-surgical procedure, and it can be possible for mitral stenosis as well as aortic stenosis, but usually it's going to be on more carefully selected patients. It could be the treatment of choice for people who have non-calcified, more mobile mitral valves, and usually patients are going to be selected for aortic valvuloplasty who are usually older and at higher risk for surgical complications. Patients who are not surgical candidates can get a transcatheter aortic valve replacement, or a TAVR, which is going to be this image at the top right here. And this is an alternate option for a patient who has aortic stenosis. With surgical management, these are going to be used more for patients who require more invasive reparative procedures and replacements, such as a valve replacement. Mechanical valves versus tissue valves. So here's your mechanical valve, here's your tissue valve. There are pros and cons to both of them. Mechanical valves last longer, so they can last 20 years or more, and you're less likely to need a mechanical valve replacement within your lifetime. But the downside is that you have to be on blood thinners for the rest of your life. On the other hand, your tissue valves, they're much more similar to a natural valve. So you don't have to take blood thinners, but the big disadvantage is they really only last about 8 to 10 years. So the likelihood of someone needing another replacement of this valve is much higher. For self-management education, this is really going to include things like the possibility of developing heart failure. So what do those symptoms look like? At what point do they need to ensure that they're meeting with their provider? It's also going to include drug therapy such as diuretics, vasodilators, beta blockers, antibiotics. For example, if someone has an artificial valve, they will take prophylactic antibiotics before simple procedures like a dental extraction. And that will help to prevent complications like endocarditis. A plan of activity and rest to conserve energy will be encouraged. So you still want your patients to remain active. You don't want them to become sedentary. And this concludes our second recorded lecture for cardiac. I know it's a ton of information, so if you guys have any questions as you're reviewing everything, please do not hesitate to reach out.